What the ovary doesn't want to see is huge, massive doses of gonadotropin. That doesn't help whatsoever. All it really needs is a modest amount of FSH and LH stimulation in order to make the eggs competent. So there are four aspects to this, that the goal is to get just as many eggs, but to get better quality eggs, to get a higher baby rate per egg. And the baby rate per egg in our statistics are 4 to 5 times higher at any given age for mini IVF, as opposed to just massive overstimulation with the usual protocol with ganirelix and 450 or 600 IU of gonadotropin with Mini Pure. The baby rate per egg is 4 to 5 times higher, and we get just as many eggs. And in fact, in older women with low ovarian reserve, we get more eggs with mini IVF than with massive overdosing. So here are the four principles. We're not just talking about low dose. One, of course, is low dose. We wouldn't give more than 150 IU every other day, or maybe per day, of 150 of FSH, and that's all. And that's for FSH for recruiting follicles, and that'll recruit all the follicles you need. Giving super higher doses do not improve the quality of the eggs. They hurt the quality of the eggs. So the all that you get from a higher dose of FSH is just more aneuploidy, but you don't get more eggs. And so a low dose is all the ovary sees. We know that from our work with in vitro gonadotropin. The ovary just needs exposure for 7 to 11 days to gonadotropin for eggs to mature. Because with our in vitro maturation, we know that once eggs are recruited from the primordial follicles, it takes 4 months before they become gonadotropin sensitive. And when they become gonadotropin sensitive, they are exposed naturally in vivo to gonadotropin from the pituitary gland. Less than 7 days of exposure, and those eggs will not mature. But more than 11 or 12 days exposure, and the quality is no good. So there's a sweet spot where about 35% of eggs in the ovary at any given day in a woman's life are actually eggs that will result in a baby. More than 7 days exposure in vivo to gonadotropin and less than 12 days exposure gives you the best quality eggs. So what happens normally in the ovary is that most of the eggs are not sensitive to gonadotropin, and they go through 4 months after recruitment of genetic development that is inexorable, that leads eventually to them being sensitive to gonadotropin. And once again, more than 7 days is necessary, but less than 12 days of exposure to gonadotropin. So we know that. And the exposure to gonadotropin should be a normal physiologic exposure, what normally happens in normal natural cycles. So the first principle is just a modest amount of FSH. It's not going to give a woman miserable hormonal swings, and it's not going to cost a fortune either. But the second principle is you want to synchronize the gonadotropin stimulation to when those eggs leave that 4-month period and actually become sensitive to gonadotropin. Because otherwise, the eggs that have already had exposure to gonadotropin are now being given more gonadotropin just for ovulation induction and just for having eggs that you can retrieve from the ovary, and it's not synchronized. So you want your beginning of stimulation to start when all the eggs in that ovary that day are becoming sensitive to gonadotropin. It's synchronizing. So what do? Birth control pills. And we found for more than 18 days, or it could be antagonists, but you need more than 18 days of exposure to a suppressant like birth control pill to turn off the pituitary, so that you're really basically killing off all the eggs that have already had in vivo gonadotropin exposure before you start your own gonadotropin. And the only reason you're giving the gonadotropin is so that you can get follicles from which you can retrieve eggs. So that's the second principle. Birth control pills for 18 or more days. Less than 18 days is not adequate. More than 18 days, it could be 100 days or 200 days. It doesn't matter. You don't oversuppress. The idea of oversuppression is a complete myth. So those are the first two principles. Third principle is that you need some LH effect for egg quality. You need FSH to get recruitment, but you need LH for quality. Now, you can't give LH pharmacologically because it's got a half-life of an hour, and they don't make it anymore for that reason. So how do you get LH effect? Well, most programs will give you Minipure or microdose HCG. It's very popular, but it also causes apoptosis or cell death. So Minipure helps egg quality to some extent, but it also kills cells. And what you really want is LH. And there's a simple way to get LH. It's got to come from your own pituitary, and that's with Clomid. So you just give 50 milligrams of Clomid a day, along with the FSH 150 every other day. And that's ideal. You get your own LH causing egg quality, and you get the low dose FSH recruiting follicles so you can retrieve them from the ovary. And then there is a fourth aspect of mini IVF. You keep them on the Clomid until the day of trigger. Usually people give Clomid for 5 days, thinking they'll give the uterine lining a chance to recover from the anti-estrogen effect, but that's silly because it takes 3 months to recover from the anti-estrogen effect. So we freeze those embryos and transfer them 3 months later. However, we continue the Clomid because it's an anti-estrogen. And that's the best way to prevent premature ovulation. If you hit them with a full dose of ganirelix, you're turning off their own pituitary gland, and you're turning off that fuel that they need for egg quality. And better just to have that anti-estrogen effect of the Clomid stay with them for 10 days or 11 days until the day of trigger. And then you're really get the best quality egg. So those are the 4 principles of what we call the mini IVF protocol. It's not just low dose. It's a protocol that exactly mimics what the eggs want to see in a natural cycle. However, unlike a natural cycle, you know exactly when you're going to be able to retrieve the egg. You don't have premature ovulation, and you get multiple follicles. So, but otherwise, it mimics the natural cycle and gives us the kind of stimulation that the eggs really want to see normally in the ovary. So that's a scientific explanation of it and how it's different from just low dose.
That's really interesting. So my question is, do you get patients, excuse me, do you get patients who push back on the birth control pills?
Well, yes, people wonder because they're coming to see me to get pregnant, not to have contraception. So I explained to them it doesn't have to be birth control pills. It can be ganirelix, it can be Lupron, anything that turns off the pituitary gland, such that all the developing follicles that have had prior exposure to in vivo gonadotropin, they're gone. And so all we're getting are the good quality follicles synchronized exactly to when we start stimulation so that they will get more than 7 days of exposure to gonadotropin, but not more than 12 days. And so they get the right exposure that is what naturally eggs really are geared to get and what they want in order to give us the best quality eggs. So I just tell them it's just a tool. It's not, I laugh and I say it's not for birth control. It's just the cheapest way of turning off your pituitary temporarily. And it's not a long time. It's like 18 days. It's not that we've figured out that you don't need any more than 18 days of exposure, unless if you've got PCOS and you don't know when your periods are and you're starting in mid-cycle, then 30 days would be best. That's just to cover yourself. But really, if you're starting with the beginning of a cycle, all you need is 18 days of exposure.
When you see a patient, what is the criteria for mini IVF?
Well, it used to be, this goes back to 2003. We used to develop this for poor prognosis patients, women over 40, women with low ovarian reserve. And our results are fairly spectacular with older women using that approach. But then we started using it for younger women and women with normal ovarian reserve. And at this point, since 2003, we find it's the best protocol for anyone. The only difference is if they have a high ovarian reserve or a normal ovarian reserve and they're under 40, we will give them 150 every day of FSH. That's the only difference. Whereas if they have a low ovarian reserve at any age or they're over 40, we'll give them the FSH low dose every other day. And that's the only difference. Otherwise, we find that mini IVF is really a way of recreating the natural cycle, however, doing it in a way that we get more than one egg and we don't have to worry about premature ovulation. And we just get the better quality eggs that way. It's 4 to 5 times higher baby rate per egg.
Do you think that mini IVF is catching on now?
I think more and more people and doctors realize that that's the way to go. And I agree it's catching on. However, many misinterpret it. And the reason for this podcast is to clarify that for people. This is not just low dose stimulation. That will not accomplish much. You have to first suppress so that you synchronize the stimulation to the day that the follicles emerge from the inert phase and become sensitive to gonadotropin. You have to keep them on the Clomid. You have to keep them on that until the day of trigger to prevent premature ovulation and don't use ganirelix. And you and those are really, really crucial features and very simple, so simple features of it. And most of the programs don't get it, and they want to give a higher dose, or they just are not understanding that you can continue the Clomid. But to do that, you do have to freeze those embryos and transfer them 3 months later.
So why do you think there are some REIs that are hesitant to do IVF?
Well, I think that the problem, a lot of REIs are really bombarded by the drug reps, and the drug reps hate this. They just want you to use a 450 IU of gonadotropin, and they consider Clomid to be a archaic atavistic drug, and it is. It's more than 70 years old, and they just really convince you that you have to use those high doses, and so you feel like you're out of it if you're doing the mini IVF. Is such a different protocol that you're afraid that you're not within the industry standard, but it really works so much better, and the patients prefer it. It gives a much higher success rate.
What would be a case that mini IVF would not be a good option?
Well, it's not an option if you don't do it right. For example, what about a PCOS patient? They are the ideal patients for mini IVF in a way because they have a huge number of eggs, all of them. And that huge number of eggs will make it very resistant to gonadotropin because they're inhibiting their pituitary gland all the time with a huge amount of inhibin and estrogen coming from their ovaries. And with PCOS patients, it's really important for them to kill off all those extra developing eggs that are inhibiting the pituitary gland. I mean, the non-gonadotropin sensitive eggs that are developing over 4 months from being recruited from primordial follicles to becoming antrofollicle GVs. I mean, those eggs aren't a problem. That's just great. But you want to kill off all the developing follicles, which are usually old eggs, they're not good quality eggs, and that's going to require 30 days of birth control pills. So if she's a PCOS patient, then you really have to give her 30 days of birth control pills before the mini IVF. And many of them will not respond to every other day gonadotropin. We reserve that mostly for patients with low ovarian reserve who are older. But the PCOS patients will need 150 every day, which is still a very low dose. Furthermore, they all have to be triggered with Lupron. They must not be triggered with Ovidrel or HCG because that could really be dangerous. So standard mini IVF, I think, just has to be modified a little bit for PCOS patients. But we've just done this now for 26 years in every type of patient you can imagine, and it just seems like it's the ideal stimulation protocol that mimics the natural cycle without losing numbers of eggs, and for any category of patient, really.
Okay, great. So I have patients sometimes that come in and they say, I want the kitchen sink protocol. Just throw everything at me. Well, what do you think about that when a patient comes to you and says that?
Well, yeah, there are many women that are very, very frustrated because they've been through cycle after cycle and not getting pregnant, and they just want to, and everything seems to come out okay, except they're just not getting pregnant. And and they want growth hormone, and they want metformin, and they want DHEA, and all kinds of dietary supplement additives. And I just say to them, you haven't really been treated scientifically yet. Let's just go with the science. let's just go with the data and go with the science for a change, because too many programs are like factories, and you take this off the shelf and you take that off the shelf and you run them through a rote process. And most patients tell me in most IVF centers, they kind of feel like cattle. They're just being herded along without really individualizing their situation. And so you got to just tell these patients it's time to go with the science. Now, natural cycle, we've done a series of 24,000 natural cycles, and we published it in 2017, Fertility and Sterility, and we called it the intrinsic fertility of the human oversight, because it was natural cycle, single embryo transfer. And the baby rate per egg was just 4 to 5 times higher than per egg than what you get with your regular cycles. And it was a great graph that went like this. Of course, it went down with age. By age 35 to 40, it began to go down. But at any given age group, the baby rate per egg was 4 to 5 times higher than in any published hyperstimulation cycle. Pasquale Patrizio published papers a long time ago showing that there's only about a 4% baby rate per egg with maximum stimulation cycles in women under 40. And we would say that that should be 15 to 20%, not 4%. And so what we need to do is go strictly with the science. And that science is based on ovary transplant, watching the egg development from the date of primordial follicle recruitment to when it leaves the IVD phase, we call the recruitment phase, and becomes sensitive to gonadotropin. And then when it becomes already too sensitive to gonadotropin, so it degenerates. And we follow that with stem cells in animals, and the stem cells converted into oocytes and then fertilized. And we've got the different stages of development, and they're very, very similar in all animals and in humans too. And we published that there's that IVD phase of 4 months after recruitment from primordial follicles where the oocytes are totally inert hormonally. And then they emerge from that and become sensitive to gonadotropin. And so we got to understand in the natural world, that's what oocytes want to see. And the only thing with IVF is we'd like to get more than one egg, and we would like to not have to lose the egg because of premature ovulation. So the Mini IVF allows us to basically get a natural cycle result, but just as many eggs as we would get if we were to massively stimulate them with huge doses of hormones. And so we just try to explain to that we're just going strictly with the science and with the data. We're not pulling stuff off the shelf. This is what the science tells us.
So that makes me think about numbers. So a lot of patients, especially after retrieval, they ask me, I got this, is that normal? And I always am like, well, it varies. How do you approach that question?
That's a good question, because some people, of course, are not going to have a good cycle. And we have to tell them there are variations. This is women with low ovarian reserve. I'll tell you what happens. Normally, the recruitment of primordial follicles, resting follicles, come from that outer cortex, the outer 1 millimeter of the ovary. And no one before us had really figured out what is the trigger for that recruitment. And I work with Hayashi very closely in Japan, and we found that it's strictly tissue pressure. The ovarian cortex is the toughest, densest tissue in the body. It's tougher than the Achilles ligament, tougher than the inguinal ligament. It's very compact, fibrous tissue. A lot of pressure. And that pressure is what keeps all these eggs, which are arrested in meiosis, from developing and then all being gone before the baby's even born, or being gone before you grow up. It's a tissue pressure gradient that controls it. And recruitment occurs in the lower tissue pressure. Now, what happens is that in the higher tissue pressure, the nuclei in those eggs are rotating. And so those eggs are dormant and arrested and not active because the nuclei are rotating, which is caused by pressure. But when you get to a lower pressure gradient, closer to the inside of the ovary, the nuclei stop rotating, and that results in recruitment. And recruitment simply means that meiosis is resuming. And that means it's going through a process that's inexorable over the next 4 months of genetic preparation for sensitivity to gonadotropin. And it's a beautiful mechanism that God made so that you don't lose all your eggs all at once. It's a method for allowing you to have eggs until you're 50. And because these eggs are just totally dormant with the nuclei rotating. But then when those eggs reach the gonadotropin sensitive phase, you got to act, or that's it. And that means they've got to be exposed to gonadotropin for the right sweet spot time. And then they become competent oocytes that can become babies. And so with that approach, the baby rate per egg is 25%. Whereas with the standard stimulation approach, which pretty much destroys that whole system, the baby rate per egg is only 4 to 6%. And so we just have a higher baby rate per egg. But we don't want to lose the number of eggs just because we're stimulating in a more mild way. And so we found that that threshold is about 150 IU per day, where you're actually getting just as many eggs. It's just that you're not ruining the eggs, and you're getting better quality eggs.
Right. So when I talk about IVF patients, I always have to tell them, expect like this many will be retrieved, this many are going to be mature as the numbers go down.
Yeah.
So with Mini IVF, do you not have that decrease as the embryo is growing?
Yeah, it's more, and I didn't mention this, when women with low ovarian reserve, the recruitment still occurs by pressure gradient. However, when a woman has a lot of ovarian reserve, then her whole ovarian cortex is pretty much similarly distributed with primordial eggs. However, when she gets older and has a low ovarian reserve, there are areas around the outside of her ovary that are very deficient in oocyte numbers. It's not an even dispersion. It's like globules. There are areas with a larger number of eggs and areas with a smaller number of eggs. So it depends on where the recruitment occurred from the earlier month. So if we have an older woman with low ovarian reserve and one cycle produces no eggs even, we tell them that doesn't mean you don't have eggs, because the next cycle might be. There may be eggs going through that 4 months of inexorable, non-hormonal sensitive development that were recruited from an area of the cortex where there were more eggs, even though this month came from an area that didn't have many eggs. So we'll try again next month. And lo and behold, all of a sudden we have 3 or 4 eggs, which is fantastic for a woman with low ovarian reserve. And we might get 3 or 4 eggs the month after. And then the following month, we might get nothing. So in older women, we're trying to accumulate embryos because it's a lower baby rate per egg to give them the highest chance of pregnancy, rather than just doing a transfer every month. And because if we do a transfer and she miscarries, it might be 6 or 8 months later before we do it again, and time is against her. So we're just trying to accumulate enough embryos statistically that will create a chance of success that is equivalent to if she were younger or if her eggs were younger. So, but we just tell her that 1 month may be different from another for the reason I mentioned. And we don't notice that as much in women with a high ovarian reserve, because the primordial eggs on the outside of her ovary are evenly distributed. Whereas when she has very few eggs, they're kind of clumpy.
That makes sense. So when someone is doing Mini IVF and they want to do multiple cycles after they get the retrieval, they get their period, they go back OCPs for 18 days.
Yeah. Absolutely. But I don't want you to get the wrong idea. That's for women with low ovarian reserve. For women with normal ovarian reserve, we want to just get them pregnant with 1 cycle. If we have 3 blastocysts, that's usually enough for almost 100% chance, almost, of at least 1 baby. And so we want to get them pregnant with 1 cycle. But if they're older and the baby rate per egg is lower, then we would like to do several cycles to try to store up more embryos.
Okay, that makes sense. So what is the next big innovation in IVF? What do you think is on the horizon for our field?
Well, it may be 10 years away, but right now we've been able to take women who are in their 50s and menopausal and make good primordial germ cells, PGCs. Now, we've done that in the mouse all the way, and we can turn those PGCs into competent eggs that become healthy baby mice. So we know it can be done. But the transcripts for doing that are different, and they're species specific. So, for example, once you have those PGCs in the mouse, you have to incubate them with fetal granulosa cells. Adult granulosa cells won't do it. And we don't know what are all the transcripts that fetal granulosa cells make that primordial follicle become a competent oocyte that's sensitive to gonadotropin. But we can do it with fetal granulosa cells. We know that. So what we've done now in the mouse is now we can make fetal granulosa cells from stem cells also, because we have the transcripts that we figure out from early embryology will convert a stem cell into a fetal somatic ovarian cell or a fetal granulosa cell. So in one culture dish, we're making primordial germ cells. We're just recreating embryology from skin biopsies converted to stem cells. And in the other dish, we're creating fetal granulosa cells from stem cells. We put the two together, we get competent eggs that make baby mice. When we did that with human PGCs, which I told you we make readily, with fetal granulosa cells from the mouse, we get a cell that looks kind of like an egg, but it doesn't develop. It's not competent. So we know that it's species specific. So what we're working on now is finding out what are the transcripts in the human for making fetal granulosa cells. When that happens, we'll be able to do a skin biopsy in women that have no eggs, convert the skin cells to PGCs, which we can do already, and then with a different culture system, create fetal granulosa cells from her and culture her PGCs in those fetal granulosa cells, human fetal granulosa cells, and make normal eggs. And I think in 10 years we'll have that. And so in 10 years, instead of retrieving eggs, we might just be doing a skin biopsy. You might go to a dermatologist instead of an REI.
We'll tell the other area.
Yeah.
That's actually really fast.
Now, the other thing we're on the verge of
turning real.
Now, the other thing that's really new, and I must say, we've been very successful using the principles of in vitro oogenesis to do IVM, in vitro maturation of eggs. So we take out the ovary of cancer patients before they have their cancer treatment so that we can freeze them and then transplant them back later after they've been cured of their cancer. We've been doing that a long time, since 1997. And now, when we take out that ovary, we are able to actually mature many of those cells into primordial germ cells and into healthy oocytes, mature eggs, and we can freeze those mature eggs. So when we freeze her ovary, we don't only have an ovary tissue for transplantation back, but we also have mature eggs frozen that can be used for IVF. Well, so our IVM, we call it, is very successful, and we get a very high maturation rate of these eggs. But that's only with ovaries that were resected to be frozen. But what the Vietnamese are doing now, will eventually be doing, they are brilliant at this. They're able, with a needle, with patients that have PCOS mostly, to aspirate these tiny follicles and do IVM. It's no different than what we're doing with taking out an ovary, getting successful IVM. And the younger patients have a higher maturation rate than the older patients. But if you can just aspirate those little tiny follicles, which most people haven't been able to do, and you do IVM the way we've been doing it routinely with ovary tissue, a patient could come into your office with PCOS and you want to get pregnant, and instead of waiting for a period or putting her on birth control pills or stimulating her or planning a target date and ultrasounds and blood hormones and all that, you just say, well, come into the clinic tomorrow. We'll retrieve your eggs. We'll do IVM and we'll fertilize them, and then we'll freeze the embryos and we'll transfer them to you several months later. Well, that's what they're doing in Vietnam now. So, I mean, the future is here, and we just have to adopt that, where the woman won't even have to go through any stimulation at all.
I think there are many women very grateful.
It's going to be fantastic. Now, I think we'll be doing that in another year or two.
Wow, that's amazing.
Just eliminate stimulation and just retrieve the eggs on any particular day of the week, and then do in vitro maturation.
Okay, that sounds awesome.
Yeah.
Well, it's coming to an end, so I just wanted to thank you so much for coming on to the Repro Files. I actually learned a lot, and I'm really excited to learn about these new innovations coming out, and I am really looking forward to the next year, 10 years of this new innovation.
Well, I am too, and I really appreciate your asking me about it so I have a chance to share this with people.
Yeah, that's really exciting. So again, thank you so much for coming on. You. Hope everybody learned something. And if you have any questions, you can always send it to us. You can go forward it and ask him if he could respond to us. But we will be here next time with Elizabeth, who is out campaigning, and she'll be back soon.
And I'm happy to answer anybody's individual questions and talk to people one on one. Thank
Awesome.
you. Okay. Bye bye.
Thank you.